Good morning. It is now, 1 p.m. East Coast time, and welcome everyone. This is Grace Lee, Chair of the Advisory Committee on Immunization Practices. I believe today is January 5th, 2022, and I am pleased to call today's emergency ACIP meeting to order. I'm going to turn it over first to Dr. Melinda Wharton to share today's announcements. Dr. Wharton?
Thank you. Next slide, please. Good afternoon and welcome to the January 5th virtual ACIP meeting. Copies of the slides being presented at today's meeting are available or will be available on the ACIP website. Additionally, slides are available through a share file link for ACIP voting, liaison, and ex officio members. A few notes on meeting logistics for those who are listening on the Zoom line. Please mute your lines at all times unless you're called on for discussion. When Dr. Lee opens the meeting for discussion, please use the raise hand function in Zoom to virtually raise your hand. During the discussion period, Dr. Lee will take questions first from our voting ACIP members and then from ex officio and liaison representatives. Please disable your video except when we're voting, and during the votes, we'll ask ACIP voting members to turn on their video. Next slide, please. The Advisory Committee on Immunization Practices is, at its heart, a public body. Engagement with the public and transparency in our processes is vital to the committee's work. For this meeting, we will be holding one oral public comment period at approximately 2:30 p.m. Eastern Time. To create a fair and more efficient process for requesting to make a public comment, people interested in making an oral comment are requested to submit a request online in advance of the meeting. Priority is given to these advance requests, and if more people request to speak than can be accommodated, we conduct a blind lottery to determine who the speakers will be. Speakers selected in the lottery for this meeting have been notified in advance of the meeting. Members of the public can also submit written public comments via regulations.gov using docket number ID CDC 2022-0002. Information on the written public comment process, as well as information on how to make a comment, can be found on the ACIP meeting website. Next slide. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forgo participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflicts of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of a concerned company, a member may participate in discussions with the provision that he or she abstains on all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. Next slide. And with that, I will return the podium to Dr. Lee.
Thank you, Dr. Wharton. Before we get started with roll call today, I just wanted to remind the public that because this meeting was again scheduled on an emergency basis, not all of our members could be in attendance today or maybe in partial attendance due to responsibilities that could not be rescheduled at the last minute. I want to thank our committee members for accommodating this emergency meeting once again, and again acknowledge and sincerely thank many of our colleagues who are covering for us today, and I'm just going to call out one of my colleagues who is covering my inpatient service for this week, so that our members can be present and available for these discussions. Their public service often goes unrecognized by the public, but we want them to know how grateful we are for their support and their willingness to go above and beyond, even though all of us are exhausted by this pandemic. I will now take roll call, starting with ACIP members and then ex officio members and liaisons. And for the ACIP members, I'll ask that you state your name, affiliation, and whether you have any conflicts of interest. So today we are going to start with Dr. Alt.
My name is Kevin Alt, and I am a professor of obstetrics and gynecology at the University of Kansas Medical School in Kansas City, Kansas, and I have no conflicts.
Thank you. Next, we'll move to Ms. Bata.
Good afternoon. This is Lynn Bata. I am the clinical immunization consultant at the Minnesota Department of Health, and I have no conflicts.
Thank you, Ms. Bata. We'll move on to Dr. Brooks.
Oliver Brooks, Chief Medical Officer at Watts Healthcare Corporation, Los Angeles, California. I have no conflicts.
Thank you, Dr. Brooks. Next, I see Dr. Sarah Long.
Good afternoon. This is Sarah Long. I'm Professor of Pediatrics at Drexel University College of Medicine and Pediatric Infectious Disease Doctor in Philadelphia, and I have no conflict.
Thank you. Dr. Chen.
Wilbur Chen, Professor of Medicine at the Center for Vaccine Development and Global Health at the University of Maryland School of Medicine. I have no conflicts.
Thank you, Dr. Chen. Dr. Sineas.
Good afternoon. I'm Dr. Sybil Sineas. I'm an internist and pediatrician. I am an associate professor of medicine and pediatrics at Alpert Medical School of Brown University, and I have no conflicts.
Thank you. We will move on to Dr. Daly.
Matt Daly, Senior Investigator, Institute for Health Research, Kaiser Permanente, Colorado, also an Associate Professor of Pediatrics, University of Colorado School of Medicine. Thank you.
Thank you. And, I just want to recognize many of our colleagues are sitting in clinics covering patients for other colleagues as well. Dr. Cotton.
Good afternoon, Dr. Camille Cotton. I am the Clinical Director of Transplant and Immunocompromised Host Infectious Diseases at Massachusetts General Hospital and Associate Professor at Harvard Medical School. I have no conflicts. Thank you.
Thank you, Dr. Cotton. Dr. Lair?
This is Dr. Jamie Lair. I'm a family physician in Ithaca, New York, and I have no conflicts.
Thank you. Dr. Paling?
Good afternoon. This is Kathy Paling. I'm a professor of pediatrics and epidemiology and prevention at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist. I have no conflicts. Thank you.
Thank you, Dr. Paling. Dr. Sanchez.
Good afternoon. I'm Pablo Sanchez, Professor of Pediatrics at Yohava State University, and I'm a neonatologist and pediatric infectious disease specialist at Nationwide Children's, and I have no conflict. Thank you.
Thank you, Dr. Sanchez. Dr. Talbot.
Good morning, or good afternoon. I'm Kip Talbot. I'm an Associate Professor of Medicine and Infectious Diseases at Vanderbilt University Medical Center, and I have no conflict.
Thank you. And this is Grace Lee. I am Professor of Pediatrics at Stanford University School of Medicine, Associate CMO for Stanford Children's Health, and I have no conflicts. And I will, there may be additional members joining later. I will call on them when they arrive. So for our committee today, we do have quorum and we're able to proceed. For the ex officio and liaison members, I will announce the organization name and please indicate if you are present in your first and last name. So for our ex officio representatives, we'll start with the Centers for Disease Control and Prevention.
Good afternoon, Sam Posner, present.
Thank you, Dr. Posner. Center for Medicare and Medicaid Services.
Good afternoon, this is Mary Beth Hans representing CMS.
Thank you. Food and Drug Administration.
Good afternoon, Doran Fink, present.
Thank you. Health Resources and Services Administration.
Good afternoon, this is Mary Rubin, present.
Thank you. Indian Health Service.
Good afternoon, this is Dr. Matthew Clark, present.
Thank you. National Institutes of Health.
Good afternoon, John Bible, present.
Thank you. And Office of Infectious Disease and HIV/AIDS Policy.
Hello, this is David Kim, present.
Thank you. We will move on to our liaison representatives, starting with the American Academy of Family Physicians.
Pamela Rockwell, Professor of Family Medicine, University of Michigan, AAFP Liaison.
Thank you. American Academy of Pediatrics.
Bonnie Maldonado, Professor of Global Health and Infectious Diseases, Stanford University, and Chair of the American Academy of Pediatrics Committee on Infectious Diseases.
Thank you, Dr. Maldonado. American Academy of Pediatrics Red Book.
David Kimberlin, Professor of Pediatrics at the University of Alabama at Birmingham and editor of the American Academy of Pediatrics Red Book.
Thank you. American Academy of Physician Assistants.
Marie-Michelle Léger,
representing the American Academy of Physician Associates.
Thank you. American College Health Association.
Katie Chai and Sharon McMullen, present.
Thank you. American College of Nurse Midwives.
Carol Hayes, present.
Thank you. American College of Obstetricians and Gynecologists.
Dr. Linda Eckert, Professor of OBGYN and Global Health, University of Washington, present. Thank you.
Thank you. American College of Physicians.
Good afternoon, Jason Goldman, General Internal Medicine, Affiliate Associate Professor, Florida Atlantic University, representing American College of Physicians. Pleasure to be here.
Thank you. American Geriatric Society.
Ken Schmader for AGS.
Thank you. America's Health Insurance Plan. We'll come back. American Medical Association.
Sandra Freihofer, practicing general internist in Atlanta and adjunct associate professor of medicine at Emory, representing the American Medical Association.
Thank you. American Nurses Association.
Chad Riddle, representing the ANA here.
Thank you. American Osteopathic Association.
Stan Grogg, President, and good afternoon.
Thank you. American Pharmacists Association.
Morning, this is Dr. Michael Hoag, Dean and Professor of Pharmacy at Loma Linda University School of Pharmacy and as a Professor of Preventive Medicine, Loma Linda University School of Medicine, representing the American Pharmacists Association.
Thank you. Association of Immunization Managers.
This is Molly Howell, Immunization Director from the North Dakota Department of Health, representing AIMS.
Thank you. Association for Prevention, Teaching, and Research.
Rick Zimmerman from the University of Pittsburgh School of Medicine, present.
Thank you. Association of State and Territorial Health Officials. We'll move on to Biotechnology Innovation Organization.
Good afternoon. Phyllis Arthur, representing BIO.
Thank you. Council of State and Territorial Epidemiologists.
Dr. Lee, Susan Lett is on for CST. She may be having audio problems.
Yes, thank you. We'll count her as present. Canadian National Advisory Committee on Immunization.
Hello, Shelley Deeks, the chair of NACI.
Thank you for joining. Infectious Disease Society of America.
Happy New Year. This is Jeff Stuchin, Health Officer, Public Health, Seattle and King County, and Professor, Division of Infectious Diseases at the University of Washington in Seattle.
Thank you. International Society for Travel Medicine.
Yeah.
Thank you, Dr. Barnett. The National Association of County and City Health Officials.
Hello, this is Matt Zahn, representing NACHO, present.
Thank you. National Association of Pediatric Nurse Practitioners.
Hello, Patsy Stinchfield, representing NAPNAP.
Thank you. National Foundation for Infectious Diseases.
This is Bill Schaffner, Professor of Preventive Medicine and Infectious Diseases at Vanderbilt and Medical Director of the National Foundation for Infectious Diseases. Thank you.
Thank you. National Medical Association.
Good afternoon. This is Pat Whitley-Williams, Professor of Pediatrics at Rutgers Robert Wood Johnson Medical School, representing the National Medical Association.
Thank you. Pediatric Infectious Disease Society.
Hello, Sean O'Leary, representing PIDS, present.
Thank you. Pharmaceutical Research and Manufacturers of America.
Good afternoon, Corey Robertson, present.
Thank you. Society for Adolescent Health and Medicine.
Hi, it's Amy Middleman, representing SAM. Good morning.
Morning, thank you. Society for Healthcare Epidemiology of America.
Hello, Marcy Drees, representing SHAE.
Terrific, thank you. Are there any individuals who have joined and wish to state their presence that I might have missed?
Good afternoon. It's Rebecca Quayle, representing the American Immunization Registry Association.
Thank you, Ms. Quayle. Great. Anyone else? Okay. We are delighted to have a few brief opening remarks today by Dr. Amanda Cohn on behalf of CDC.
Dr. Lee.
Oh, yes.
I think Dr. Marks is available. We just need to get a link to him.
Oh, okay.
So let's hang on just a moment.
Okay. Well, we'll just take a brief break until Dr. Marks can connect in. Dr. Marks, as everyone knows, is from the Food and Drug Administration, and we appreciate him joining us to make a few remarks on the sort of recent activities of the FDA over the past week. It's certainly been a busy time for everyone, so we appreciate everyone's patience, and also Dr. Marks for joining.
Dr. Lee, this is Amanda Cohn. I can, in the interim, while we are getting the link to Dr. Marks, I can go ahead and make a couple of comments on behalf of ACIP, if that's okay.
Thank you, Dr. Cohn. The floor is yours.
Sure. So I just wanted to share with everyone, first of all, Happy New Year. We are going into year 3 of this pandemic and of the ACIP deliberating on COVID vaccine recommendations. We just quickly calculated, and it appears that the ACIP met for 24 days last year alone, which is just extraordinary. So these extraordinary times over the new year, we've taken a step back, and we're thinking about the best way for ACIP to continue to inform and advise the CDC director on critical COVID vaccine issues. And as the vaccine landscape continues to evolve, there will be modifications made by FDA to EUAs and potentially BLAs based on the most current data. Dr. Marks is going to describe the most recent ones made this week by FDA in a moment. As these iterative changes occur, there will be times when the CDC director approves these changes based on a data review by CDC SMEs. These approvals do not deflect from the critical role ACIP plays in advising the director on important issues and questions related to the COVID vaccination program. We're going to make every effort this year to have ACIP meetings scheduled in advance so there will be broad awareness about upcoming opportunities for ACIP to review the data and deliberate in a public, transparent setting. I just want to remind everyone to please continue to check the ACIP websites for upcoming meetings. And if you sign up for announcements, you'll get an email notification of when a new meeting is added to the ACIP website. But we are really hoping this year that we will have a more feasible, sustainable, and approach to meetings for both all of us and all of the amazing liaison and voting members who have attended these 24 days of meetings last year, and for members of the public. So there will be more to come.
Thank you, Dr. Cohn. Dr. Wharton, do we have Dr. Marks on the line?
I do not see him yet.
Thank you.
So I think we probably should just go ahead and proceed.
Okay, and we will invite Dr. Marks to make comment at any point during the meeting today. But I think in the interest of time, we would like to move on because I anticipate a robust discussion for today. So during today's meeting, as a reminder, Dr. Wharton mentioned I'll invite individuals to contribute to the discussion. Please raise your hands electronically, and I will call on ACIP members first, followed by our ex officio members and liaisons. And we will start today with Dr. Matt Daly, chair of the COVID-19 vaccines work group, who will provide an introduction and overview of today's meeting. Dr. Daly.
Thanks so much. So I'm going to be presenting, or at least introducing the session today on behalf of the ACIP COVID-19 vaccines work group. Next slide, please. As you can see, daily cases is on the y-axis and time is on the x-axis. This graphic almost doesn't need to be described because it's so visually striking, but I just want to highlight the fact that there's in the range of 490,000 daily cases in the U.S. at the present time, and a total over the course of the pandemic of more than 56 million cases. Next slide, please. So there are several FDA updates. Dr. Cohn made reference to these. We may also hear directly from Dr. Marks about these, but let me just highlight a few. So There's been updates with respect to Pfizer-BioNTech COVID-19 vaccine and boosting. On February 3rd of 2022, the FDA updated the EUA fact sheet for Pfizer-BioNTech COVID-19 vaccine in several ways. Here are the updates. One was to expand the use of a booster dose to include use in individuals 12 through 15 years of age. This will be the primary area of focus of today's discussion, although we will also be focusing or discussing other things and a broader overview of safety, et cetera. There have been other updates from the FDA, including allowing the use of a third primary dose for certain immunocompromised children 5 through 11 years of age. In addition, included in the recent FDA update was a shortening of the time between completion of primary vaccination with the Pfizer-BioNTech COVID-19 vaccine and a booster dose. That interval previously was 6 months, now it is 5 months. And in this, there were memoranda filed for Moderna and Janssen to allow those to be used as booster doses. This is heterologous if it's after a completion of a Pfizer-BioNTech primary series 5 months later. And this obviously applies based on product received and based on those who are eligible otherwise for a booster. Next slide, please. These were decision memos that were announced January 4th. And I will read these. For moderately to severely immunocompromised children 5 through 11 years of age, they can receive an additional primary, meaning a third Pfizer-BioNTech COVID-19 vaccine dose at least 28 days after completion of doses 1 and 2 of the primary series. Again, this is an additional dose, moderately to severely immunocompromised children, 5 to 11. In addition, those 18 and older can receive a single homologous Pfizer-BioNTech COVID-19 vaccine booster dose 5 months after completion of the primary series of a Pfizer-BioNTech vaccine. However, the interval for a booster after Moderna and Janssen did not change. So if someone received a Moderna primary series, then they can receive a booster 6 months after completion. If they received a Janssen first dose, they can receive a booster 2 months after completion of their primary series. And then in addition, for those 16 and 17-year-olds who received a Pfizer-BioNTech primary series, they can receive a booster 5 months later. Next slide, please. So to discuss the recent activity of the COVID-19 vaccines work group, in January of 2022, which basically just means yesterday, there was a combined call with the ACIP COVID-19 vaccines work group and the vaccine safety technical work group, which is otherwise known as VAST. And the groups together reviewed updated COVID-19 vaccine safety data and discussed updates to the booster dose vaccine policy. Next slide, please. So here's the agenda for today. We'll first hear from Dr. Su at the CDC. He will review updates to the COVID-19 vaccine safety data from VAERS. Then we'll hear from Dr. House at the CDC, who will review updates to COVID-19 vaccine safety from VSafe. And then we'll hear from Dr. Klein, who's from Kaiser Permanente, Northern California. She will review updates to COVID-19 vaccine safety from the Vaccine Safety Data Link. After that, we'll have a break. After the break, we'll have public comment. And then after public comment, we will hear about updates to clinical considerations from Dr. Twentyman from the CDC. Then we'll hear from Dr. Oliver from the CDC, who will review updates to the evidence to recommendations framework. And then we will have a discussion of Pfizer-BioNTech COVID-19 vaccine booster doses in adolescents, 12 to 15 years of age. Discussion will follow, after which we will have a vote on the use of booster doses in that age. Next slide, please. Would like to sincerely thank the ACIP work group members, including, this is the COVID-19 vaccines work group, including ACIP members, ex officio members, liaisons, consultants, and the outstanding leadership of Dr. Oliver. Next slide, please. And then I'd also like to take a moment to thank the many colleagues at the CDC who contributed their time and expertise to the presentations we hear today. I think that something the listening audience may not be aware of is that it takes literally hundreds of hours to prepare materials for ACIP meetings. And this isn't simply preparing slides, it's also gathering data, analyzing data, interpreting data, integrating information from multiple sources. And so I suspect that many of the folks on this slide were long overdue for vacation and had vacation planned last week, but instead spent long hours preparing the materials for the meeting today. So, for the folks on this slide, we ask a lot of you, and we greatly appreciate your service to the nation's public health. Next slide, please. So thanks, and I turn it back to you, Dr. Lee.
Thank you, Dr. Bailey. And we can't emphasize enough how appreciative we are that our CDC colleagues have been working nonstop and really have not had the holiday break that many of us were fortunate to at least have had. So thank you. I want to emphasize that over and over. Before we get started, there's a couple of announcements. First, I want to call on ACIP member Ms. McNally to state her name, affiliation, and whether she has any conflicts of interest.
Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflicts. Thank you.
Thank you, Ms. McNally, and thank you for making yourself available. And second, I'm going to actually turn it back over to the room at CDC, perhaps Dr. Oliver or Dr. Wharton, and ask if you can introduce two additional attendees and introduce them for to the committee and to the public.
Thank you so much, Dr. Lee. This is Dr. Oliver. First, we're happy to say that Dr. Marks from FDA has been able to join us, and so he can give a few comments from FDA about recent action this week. Dr. Marks?
Sure. Thanks very much for having me. And I actually would just echo thanks to all the CDC colleagues who have been working through the vacation period to keep these actions moving. So I will very briefly say something about the three actions, mainly focusing at the end on the 12 to 15-year-olds. The recent surge in COVID-19 cases, first provoked by Delta and then with Omicron on top of it, has led us to look carefully at any actions that we could take in order to enhance the protection of the population through vaccination. With that, we looked at data that had been provided to us by various companies. In this case, for the Pfizer vaccine, we were aware of the data showing that a booster could be given at 5 months after the completion of the primary series safely, and they had in 4.7 million individuals studied in a large real-world evidence study, good evidence that seemed to be effective, and in 4.1 million individuals for whom they had safety data who received the booster, again, good safety data. So in the action to bring down the booster interval from 6 months to 5 months made evidence-based sense, particularly given that we seem to understand now that protection against the Omicron variant in particular may require higher titers of antibodies, and that might be achieved sooner by allowing people to be boosted sooner. The second action of enlarging the population that would be eligible for a third dose of the primary series to include the 5 to 11 age range was really a straightforward one based on a risk-benefit consideration and the potential need in that population of immunosuppressed individuals, those who might have received organ transplants or an equivalent. We had previously brought it down to the 12 to 15 age range, and this essentially was a move based on looking at the safety data that we had to complete that and allow 5 to 11-year-olds who were either immunocompromised or had getting immunosuppressive medicines because of transplant to be able to get a third vaccine, knowing full well that still may not restore the ability of these vaccines to provide a full level of protection, but it was something else to be done. The final action is the 12 to 15-year-old boosters, extending boosters to at 5 months to the 12 to 15-year-old population. That was based on a combination of looking at the risk modeling that we had previously done as we evaluated the vaccine use in the 12 to 15 age population, and actually through the pediatric age spectrum, as well as looking at the data that came from Israel on over 6,000 children who had received ages or adolescents who had received the vaccine as a booster dose at 5 months. And given that there did not appear to be new safety concerns, and then again, given the current surge in cases, it was felt to be a reasonable action to extend the potential use of a booster dose down into this age range. One final comment on this is that from prior work that we had done and that has emerged from other sources as well, it appears that the risk of myocarditis, which is higher anyway in males, appears to peak at age 16 and 17. And so I think you'll see some data later on today that may comport with that. So that was the sum of our actions. Thanks very much.
Thank you, Dr. Marks. Dr. Oliver?
Thank you so much. We have one other person before we get with our scheduled agenda today. I want to introduce Dr. Alroy with the Israel, who's been able to join. We're incredibly privileged to have them join us today. We want to thank so much. We acknowledge that this it is considerably later there, and so they're joining us late into their evening. They've been incredible partners as we try to balance this, review data, and learn from others' experience. And so I want to thank them very much for being willing to come on today's ACIP meeting and share their experience. Dr. Alroy, feel free to, you should be able to be a co-host and share your screen if you want to show slides. Otherwise, we can pull them up here. Thanks.
Thank you so much. Hopefully you can hear me.
We can, and we can see your slides. Thanks.
All right. So I'm happy to join you. Happy New Year to everyone. I was asked to introduce or to describe the results that we have so far for the 12 to 15 years old booster vaccination campaign, and I'm happy, obviously, to share them. So why giving a booster dose? Because as in the adults, we have been seeing waning of immunity in that age group too. I'm showing you the data from the last week where the age group 12 to 15 years old is the highest group, leading group in confirmed infection, as you see in this pinkish red line going up. And so their confirmed infections are going up very steeply. Our vaccine coverage before this current wave, we started with a vaccination of the 12 to 15 years old in the middle of June, which was our fourth wave, in the beginning of our fourth wave. And as you see in the blue line, we got to 65% coverage.
I'm sorry to interrupt, Dr. Elroy. We just see the title slide right now. Is it possible to move to the next couple of slides?
Sorry, I'm moving in my computer, but it's obviously not doing the same for you. So thanks for letting me know. If I'm moving like this, can you see?
Yes, we can. Thank you.
Okay, so I'll just keep it like that. So this is the graph that is showing confirmed infection of the past week, and we see this line in red. Kind of pinkish, which is the 12 to 15, and this is the leading group, age group in confirmed infection. So they are seeing a really steep rise in their infection rate. Hopefully you can see the next slide now, if I move like that. And
yes, we can. Thank you.
Yes, we can see it.
kids, it has been usually Pfizer vaccine. So the passive surveillance is basically reports from medical staff and community and hospitals. Once they report to us and we confirm the vaccine status, which we have in our Ministry of Health, we're completing data from our health maintenance organizations and the hospitals, and we are reviewing the medical files to verify medical background and differential diagnosis. When something that is considered serious adverse report is reported to us, it is reviewed by a designated medical committee that is trying to link the adverse event to the vaccination. And then obviously there is data processing and statistical analysis, and we obviously present the data anonymously. For the active surveillance, which we started conducting in about February, we started that when we saw a signal after Pfizer vaccine vaccinations of myocarditis, and since then we have been conducting active surveillance routine. We are actually contacting all hospitals. In Israel, myocarditis is a diagnosis that is requiring hospitalization. So probably most of the cases are in the hospital. We're contacting them on a weekly basis, and based on ICD-9 codes, they're getting all the data, obviously doing QA and data confirmation, completing the medical history as needed, and then all those cases are reviewed by a designated medical committee consisting of cardiologists and rheumatologists to try to figure out the story, and actually it's all myocarditis cases. It's not just those after vaccination. So the booster safety data is very reassuring by both of those different surveillance methods. We have given over 41,000 doses, and in our follow-up, we have only 2 cases of myocarditis, both in males. One 13-year-old male, 3 days following his booster dose. He had also a medical history of pericarditis in 2019. And a 15-year-old male, 4 days following the booster dose. Both of them did not have any compromise, any cardiogenic compromise. They were both released after a few days in the hospital in good conditions. Ejection fraction was completely normal, no arrhythmia, nothing concerning. So those are the 2 cases that we had. And in addition to that, in our passive surveillance, we were reported of 2 non-serious reports, restrictions of movement and a headache. So really minimal safety signals here. And the preliminary results of the impact, and so what we saw is this is the rate, the confirmed infection rate for 100,000 risk days for age groups 12 to 15. So you're seeing the unvaccinated have obviously a very high rate of infection. After the booster, 1 to 2 months after the second dose, you're seeing a significant drop in confirmed cases, and a waning effect that happens, which basically after 5 to 6 months, those kids are having the same rate of infection as the unvaccinated group. But once they're getting the booster, about 7 to 10 days after, we're seeing a significant drop in infection rates in that group. So that's the results that we have so far from Israel, and I'm happy to answer questions if you want. I can only stay with you for a few more minutes, and I have to go to other meetings, but I'm happy to answer anything at this time.
Thank you, Dr. Elroy. I want to just thank both Dr. Marks and the entire FDA for continuing to be responsive to this public health emergency, along with our CDC colleagues. And Dr. Elroy, just really appreciate this global collaboration and response that is so sorely needed. We are going to offer this presentation open for questions, since you did offer a few minutes of your time. So I will ask if there are any members who have questions first, and then we'll open it up to liaisons and other members. I see Dr. Kimberlin is quick on the hand, so go ahead, Dr. Kimberlin.
David Kimberlin, AAP Redbook. Can you inform us a little bit more on the impact of boosters on severe disease, hospitalizations, and not cases, but actually the end extreme of what we're really trying to prevent here?
So we don't have a lot of 12 to 15 years old severe disease during the acute phase, but we did have cases of PINS in that age group, and mostly among the unvaccinated group. So we were seeing, and I can pull up the numbers, but we were seeing several, like 40, 50, 70 cases of PINS in that age group, but all of them were unvaccinated individuals. And in addition to that, we also had in that age group 2 fatalities of unvaccinated 12 to 15 years old, 1 female and 1 male, because of PINS. So we are not seeing a lot of hospitalization in the acute phase in a severe and critical conditions, but we have seen severe disease in PINS conditions, and it's roughly every 1 to 2,500 cases, all in all in children, not just in 12 to 15 years old. So we are concerned from that standpoint.
Thank you, Dr. Elroy. Are there any additional questions that our colleagues have? One question for you, Dr. Elroy. During the period of time when you've looked at the efficacy of the vaccine in terms of the rates of infection following booster compared to other intervals post the 2-dose series, what was a major circulating variant during that time?
So in our 4th wave, the major variant was Delta. Now we are seeing a combination of Delta that was starting to come down from the 4th wave, which we got to about 10,000 confirmed cases a day. We got to roughly 500 a day, and then before it was completely gone, Omicron entered. And so we now have a combination of mostly Omicron, but also Delta. And so the confirmed infection right now that I showed you the results, the impact of the booster is during a period of time when we have both Delta and Omicron.
Thank you so much. Dr. Long?
Yes, it's a question for Dr. Peter Marks. In the decision to provide a 3rd dose for 5 to 11-year-olds with immunocompromising conditions, did you have any antibody data on any children of that age group to understand their responses after 2 doses, or was it a decision based on supposition?
Yeah, no, thanks for that question. This was based on essentially the way we do immunobridging to older individuals, and so the analogy here was in that population getting a lower dose of vaccine, they would have a similar response to the 12 to 15-year-olds who would have a similar response to the adults in terms of not having a good response to this. But we would also just say that we expect that many of these children will be treated at transplant centers where they may be using either quantitative or semi-quantitative assays to assess antibody levels, because that's the only way one will actually know that somebody has actually responded after a 3rd dose. So we suspect that there will be some data that will come from that as use goes on. Over.
Thank you. I just want to do a last call for Dr. Elroy because I want to just recognize that she has generously donated her time to us and to another meeting. Okay, thank you so much, Dr. Elroy and Dr. Marks, for making yourselves available to the committee and to the public to share your information, and we really appreciate it. We will, if there are additional questions, please just let us know, and we will try and follow up afterwards. But we do need to move on to the next part of the meeting. Thank you again. So we'll move on to Dr. John Su, who will present updates on the COVID-19 vaccine safety updates from the VAERS team. Dr. Su.
Good afternoon. I hope everybody can hear me okay. Go to the next slide, please. Excellent. And the next slide, please. So I'll just be covering some data on primary series after Pfizer-BioNTech's mRNA vaccine for children and adolescents ages 5 through 11 and 12 to 15 years. Really, the 5 to 11-year-old data is just sort of an update on existing data. We'll also be sharing data to VAERS after Pfizer-BioNTech's booster vaccination in adolescents and adults aged 16 to 24 years. Next slide, please. So just a reminder that VAERS is the nation's passive surveillance system and is designed to be an early warning system. Next slide, please. And so because it's a passive surveillance system, VAERS is quite sensitive. And so some of its strengths include rapidly detecting potential safety concerns, as well as previously unreported adverse events. However, one key limitation of a passive surveillance system is the fact that you can have incomplete data, but perhaps most notably, you generally cannot use VAERS data to determine whether or not the vaccine caused the reported adverse event. And that's just something we try to emphasize. Next slide, please. So moving on to data on children and adolescents ages 5 through 11 and 12 to 15 years. Next slide, please. So on this slide, we show by age group just some descriptive data, including on the right, median age, breakdown by sex, by serious status, as well as total reports and doses administered. And really, I think the take home from these data is that for either age group, most reports, better than 92%, were non-serious, and that distribution by sex is quite similar. Next slide, please. So here we show the race and ethnicity data for these different age groups, with race ethnicity on the left, followed by age groups on the right. And really, this kind of reflects some of the limitations of VAERS in that one of the most frequently reported data are those folks who did not report any data, otherwise of white, non-Hispanic race and ethnicity. Next slide, please. So here we're showing the most frequently reported adverse events to VAERS among children and adolescents ages 12 to 15 years. On the left, we show the 8 most frequent adverse events reported among non-serious reports, and on the right, those that are serious. And these typically reflect vaccination error as well as previously observed adverse events, as well as workup for myocarditis and multi-system inflammatory syndrome in children. You may note that there are some results over here that reflect normal findings, and I'll walk through a hypothetical on the next slide just to illustrate how that can happen. Next slide, please. So this slide presents data on the most frequently reported adverse events after Pfizer-BioNTech's vaccine in children 5 to 11 years of age. Again, on the left, the most frequently reported adverse events for non-serious reports, and on the right side for serious reports. And again, these tend to reflect, you can see for non-serious reports, a lot of vaccination error. And I will add that when people report vaccination errors, they often explicitly state that no adverse event occurred. And that's why you can see that as the number one adverse event, if you will, being reported. If you go past the top 8, so if you look at, say, 9, 10, and so forth, you see a continuation of adverse events that have been previously observed after Pfizer-BioNTech's vaccine, things like things like fatigue, pain at the injection site, that sort of thing. And just to walk through that hypothetical I was talking about, let's say, for example, that you have a patient who, after vaccination, 2 days later, develops chest pain bad enough to cause vomiting. They get seen in the emergency room, and the physician orders a battery of tests, perhaps serologies to look at previous exposure to SARS-CoV-2, maybe a troponin, maybe because of concern for MIS-C, maybe ordering a C-reactive protein, as well as some diagnostic imaging such as echocardiography, perhaps an EKG. And so we can see that in some of that testing, you may end up with normal results. But the medical coder, when assigning standardized codes to these reports, might still include them in the report itself. And that's why on their series reports, for example, we can see things like a normal echocardiogram or a negative SARS-CoV-2 test, because that reflects what some of the diagnostic workup was performed for that given patient. So just so you can have a better understanding of how we can end up with adverse events that don't really necessarily indicate a negative outcome. Next slide, please. On this slide, we show reports of myocarditis among children and adolescents aged 12 to 15 years. We start with 317 preliminary reports of myocarditis in children these ages, and the flow diagram on the right shows how we ultimately adjudicated 265 reports that met the case definition of myocarditis. Median age for these reports was 14 years, and much of the data here reflects what we've seen in older age groups, with a median time to onset of 2 days, most reports being after dose 2, and most being after males. There were some 251 patients known to be hospitalized. Most of them were discharged home. There were 224 patients for whom we had known outcomes, and most of these folks had recovered from their symptoms at time of report. There was a small proportion for whom were not fully recovered at time of report, but had reported improving or resolved symptoms, but remained on physical restrictions, and some remain under investigation. And just for context, during the time period here, we had 18.7 million doses administered to this population. Next slide, please. This slide shows the same data for children ages 5 to 11 years. There were 16 preliminary reports of myocarditis identified, 12 of which were verified to meet case definition. The median age was 10 years, and like for 12 to 15 years, much of these data reflect what we've seen with older age groups, with a median time to onset of 2 days, most reports being after dose 2, again, most being after males. Of these 12 reported cases, all patients were discharged home. 8 were recovered from their symptoms at time to report. There's another 4 who are still recovering at time to report, much like what we saw in the previous slide. One thing I'll add is you might recall that for non-serious reports, there was a large proportion of vaccine errors being reported. And I just want to point out that of these 12 reports of myocarditis, none reported a vaccination error. And again, for context, 8.7 roughly million doses of vaccine had been administered to this population. Next slide, please. So on this slide, we show estimated reporting rates of myocarditis per 1 million doses administered during the 7-day risk period after vaccination. And so on the left side, we show by age group, and we include 16 to 17-year-olds here just as a point of reference. And then on the right side, broken down by sex and then by dose number, the estimated reporting rate. There were about 37.8 million doses of dose 1 or dose 2 of vaccine administered. And for reference, the background incidence during this risk period is anywhere from 0.2 to 1.9 per 1 million person 7-day risk period. And so values here that exceed that range are highlighted in peach. And what we see over here is that there is an elevated rate among males after dose 1 for ages 12 to 15 and 16 to 17 years, and after dose 2 for all 3 age groups reported. But I will note that there's a very large difference between 5 to 11 and the other age groups. We also see elevated rates among females after dose 2 for ages 12 to 15 and 16 to 17-year-olds. One thing that I'll add is that we are very early in the vaccinations for children 5 to 11 years of age, and so we anticipate that there may be some reporting biases at play, and we expect these numbers to vary some. And as the data mature, we'll see hopefully more stable rates later down the road. Next slide, please. So to briefly sum up, since authorization, there have been 8.7 million doses of Pfizer and BioNTech's COVID-19 vaccine administered to children ages 5 to 11 years, and 18.7 million doses administered to children and adolescents 12 to 15 years of age. Regardless of age group, most reports were non-serious. The most frequently reported adverse events were known and well-characterized adverse events. We do have reported myocarditis among children ages 5 to 11 years. Most were after males and mostly after dose 2, consistent with older age groups. And reporting rates for males aged 5 to 11 years were substantially lower than for males of older age groups. And CDC will be continuing to monitor vaccine safety among these age groups. Next slide, please. So shifting gears and talking about booster vaccination among persons 16 to 24 years of age. Next slide, please. And again, these are after Pfizer-BioNTech's vaccine. We can see here some general descriptive information on the left broken down by age group, and on the right by sex, serious status, total reports, doses administered. And again, I think the take home from these data is that most reports, better than 95%, were non-serious. Next slide, please. Here we show some of the race and ethnicity data for these age groups. Boosters were only recently authorized for 16 to 17-year-olds, so you can see we really don't have much data there. And for 18 to 24-year-olds, the data are quite consistent with what's been reported previously. Next slide, please. Here we report the most frequently reported adverse events, and because we are so early in vaccinations among 16 to 17-year-olds, we just present the aggregated count of serious and non-serious for the entire 16 to 24-year-old age group. On the left, the most frequently reported adverse events among non-serious reports, and on the right for serious reports. And again, these tend to reflect previously observed adverse events as well as workups for myocarditis. Next slide, please. Among these patients, we did identify 13 preliminary reports of myocarditis, 4 met case definition. Just to provide the brief descriptives of the preliminary reports of myocarditis, the median age was 21 years, median time to onset was 1 day, most were males. There were, of the 4 reports that met case definition, 2 reports among males ages 16 to 17 years, 2 reports among ages 18 to 24 years. 1 was male, 1 was female. All reported patients were recovered at the time of report, and during this time period, we've administered roughly 1 million doses of vaccine. We didn't provide any reporting rates. We are very early in the report or in the vaccination campaign using these boosters, and as the data mature, we might be able to offer this down the road. Next slide, please. So just to sum the data on booster vaccination among ages 16 to 24 years, there have been about 47,000 persons ages 16 to 17 years who've received a booster dose, and about 930,000 persons ages 18 to 24 years who've received a vaccine booster dose. Most reports were non-serious. Again, the most frequently reported adverse events had largely been known and well characterized. We had 13 preliminary reports of myocarditis, 4 of which met case definition. All 4 reported patients had recovered from symptoms at time of report, and the characteristics do seem to be consistent with what we've seen after dose 1 and dose 2. Again, CDC will continue to monitor the safety of vaccine booster doses. Next slide, please. I just wanted to thank the many people who made these data possible, including our state and local partners. Next slide, please. And we have time. I'll be happy to answer any questions. Thank you very much.
Thank you, Dr. Su. We will open this presentation for questions now. Dr. Paling?
Dr. Su, thank you very much for sharing what is available in the VAERS database. The question I wanted to ask you, it seemed to be that you were saying that these children have resolved or are resolving. And so I wanted to confirm, have you identified any deaths from myocarditis after the vaccine that met definition? Thank you.
Sure. There was one patient who who had died afterwards, and there was myocarditis identified on postmortem. What is unclear is what role the myocarditis played in the patient's demise. That report remains under active investigation. So, we don't know at this time what role vaccination, or at least what role myocarditis played in that patient's death.
Dr. Daly.
Great, thanks so much. Thanks, Dr. Sue, for that presentation. I have a comment and then a question. The comment is that I appreciate seeing the data on 5 to 11-year-olds, and I think there are parents out there who have concerns, including concerns about myocarditis, and maybe they're waiting to see what the safety profile looks like. So I think the fact that, I know we're early, but the fact that it appears that the rate of myocarditis is quite a bit less in this age group, I think is going to be reassuring to parents who'd like to vaccinate but are sitting on the fence. And then my question is, could you tell us about long-term follow-up plans for individuals diagnosed with post-vaccination myocarditis? Over.
Hey, thanks for that question, Dr. Daly. So currently we have a group, and what we've done is to identify those patients who were identified as meeting the case definition. And we have that group following up on these patients for those folks who are 90 or more days out from their initial presentation with myocarditis, and just reaching out to them and their providers just to get a sense of how they're doing now. We've gone through the initial follow-up with some of these patients, and I believe that we are currently analyzing those data and plan to publish those in the near future, hopefully.
Dr. Long.
Yes, it's a comment to Dr. Daly and also a comment for Dr. Sue. It seems to me that we should not conclude anything about reduced occurrence of myopericarditis in the young age group at this point, at the 5 to 11-year-olds, since we know that it is more pronounced on the second dose, and we know from the timing of the recommendations that all of those second doses, I calculate it, have to have occurred in December. And in my own family, getting them as soon as they could, non-availability, et cetera, the second dose only occurred around Christmas Day. So since it took us 4, 5, 6, 7, 8 months to get the numbers right about myopericarditis following the second dose, where originally we thought maybe it was a couple in a million and then down to 400, 500,000. And now it looks like it's about 1 in 14,000 male second doses. So I can see you're concluding for those parents waiting that there is no worrisome signal, but I think it's much too early to say, and I know it's going to be said later today, and I think we'll actually see when the doses were given, that those 8 million doses are not mainly the doses that are most prone to cause myopericarditis, so that we should be very cautious and not try to overcompensate for concern about this age group and reassuring people. Thank you.
Thank you, Dr. Long. Dr. Daly?
Yeah, Dr. Long, thanks for that, and that's a great point to make. And I don't disagree. I think it's early, but this wasn't overly alarming. And I think we did get evidence about myocarditis in other age groups sooner than 8 months, but I fully recognize we need to see what happens after dose 2, and there are limitations to the VAERS system as well. So we need to be cautious, but I still feel like it's valuable to look at the current state of what we know about 5 to 11-year-olds. Thank you.
Thank you. Are there any other clarifying questions about this presentation that people would like to ask? All right, I think we will move on. Thank you, Dr. Sue, for your presentation. We'll move on to Dr. Ann House, who will present updates on COVID-19 vaccine safety from the VSafe team. And as she's pulling up her slides, I will just state that Dr. Oliver in her presentation will have a comment from VAERS in terms of the interpretation of the totality of the safety data that was reviewed this week. Thank you.
Thank you. Can you hear me?
Yes, we can.
Okay, so today I'll be presenting an update on safety monitoring for COVID-19 vaccine among children and young adults in VSafe. Next slide. VSafe is a voluntary safety surveillance system. It allows a parent or guardian to enroll their child after any dose of COVID-19 vaccine, and children less than 16 years of age must be enrolled by a parent or guardian. VSafe allows existing participants to report receiving a booster dose of COVID-19 and new participants to enter information about all doses received and complete health surveys on their most recent dose. VSafe health surveys are sent daily during the week following each dose of vaccine and include questions about local injection site and systemic reactions, as well as health impacts, including inability to perform normal daily activities, inability to attend school or work, and receipt of medical care. Additional health surveys are sent weekly through 6 weeks after vaccination and at 3, 6, and 12 months after vaccination. Next slide. As of December 19, 2021, Pfizer-BioNTech vaccination had been reported for over 115,000 VSafe participants aged 5 to 15 years. Approximately half were female, 37% were aged 5 to 11 years, and 63% aged 12 to 15 years. 78% classified as non-Hispanic, and 68% as white. Next slide, please. This figure shows the frequency of reactions and health impact events reported at least once during days 0 through 7 after Pfizer-BioNTech vaccination by dose and age group. Children aged 5 to 11 years are represented in blue, and children aged 12 to 15 years in orange. In general, reactions and health impacts were more frequently reported following dose 2 than dose 1, and more frequently reported for children aged 12 to 15 years than children aged 5 to 11 years. Next slide. This figure shows the frequency of any systemic reaction reported for children aged 5 to 11 years and 12 to 15 years at least once during days 0 through 7 after dose 2 of Pfizer-BioNTech vaccine by days since vaccination. On the x-axis is days since vaccination. And again, children aged 5 to 11 are shown in blue and children aged 12 to 15 years in orange. Reactions were transient and most frequently reported the day following vaccination for both age groups. Next slide. This figure shows the frequency of the top 5 reactions reported for children aged 5 to 11 years and 12 to 15 years at least once during days 0 through 7 after dose 2 Pfizer-BioNTech vaccine. Injection site pain, fatigue, headache, myalgia, and chills were all frequently reported in the week following dose 2 for both age groups and were more frequently reported for children aged 12 to 15 years than children aged 5 to 11 years. Next slide. Now I'm going to shift gears a little bit and present booster data for adolescents and young adults. As of December 19, 2021, over 7,000 VSafe participants aged 16 to 24 years have reported a homologous Pfizer-BioNTech booster dose. Approximately 72% were female, 7% were aged 16 to 17 years, and 93% were aged 18 to 24 years. 84% identified as non-Hispanic, and 74% as white. Next slide. This figure shows reactions and health impact events reported at least once during days 0 through 7 after Pfizer-BioNTech vaccination by dose. odds of reporting an event following dose 2 and booster dose were compared. Those that were statistically significant are indicated by an asterisk. Dose 1 is shown in yellow, dose 2 in blue, and booster dose in green. Injection site reactions and systemic reactions, as well as health impacts, including inability to perform daily activities and inability to work or attend school, were all less frequent following booster dose than dose 2. Receipt of medical care was reported more frequently following booster dose. However, the difference is very small. Next slide. This figure shows the frequency of any systemic reaction reported at least once during days 0 to 7 after each dose of 5 days since vaccination. Reactions were transient and most frequently reported the day following vaccination for each dose. Next slide. This figure shows the frequency of the top 5 reactions reported at least once during days 0 to 7 after each dose of Pfizer-BioNTech vaccine by dose. Again, pain, fatigue, headache, myalgia, and chills were frequently reported and were less common after booster dose than dose 2.
Sorry.
Slide.
Yeah, I'm in a.
Dr. Hogue, I think
I apologize.
Next slide, please. Sorry, could I have the next slide? These data are subject to a couple of limitations. First, VSafe is a voluntary system and as such is likely not completely representative of the vaccinated US population. Second, booster doses had only recently been authorized for age 16 and 17 years at the time of this analysis, and the data were somewhat limited to describe reactions for this age group. Next slide. To summarize, Pfizer-BioNTech vaccination has been reported for over 115,000 VSafe participants aged 5 to 15 years. Reactions were generally mild to moderate and frequently reported the day after vaccination. Reactions were more frequently reported after dose 2 than dose 1. And participants aged 5 to 11 years reported reactions more frequent or less frequently than participants aged 12 to 15 years. However, children aged 5 to 11 years do receive a smaller dosage of vaccine than children aged 12 to 15 years. In addition, over 7,000 VSafe participants aged 16 to 24 years reported a homologous Pfizer-BioNTech booster dose. Reactions were generally mild to moderate and most frequently reported the day after vaccination. Also, reactions were less frequently reported after booster dose than dose 2. Next slide. I'd like to acknowledge the many people who made this analysis possible, including those who participate in VSafe. Next slide. Next slide. Thank you. I'll take any questions.
Thank you so much, Dr. House. This presentation is now open for questions. And while we're waiting for hands to be raised, I do want to make a quick statement to the public that VSafe has been an incredibly helpful resource during the COVID-19 pandemic to monitor vaccine safety, and would continue to encourage your patients, your family members, your colleagues to report into VSafe. I think it is incredibly helpful for us to have that real-time information and tracking, and particularly for our pediatric patients. I think although attention has waned a little bit, I still think that this is an important system for us to continue to support and make sure that everyone is able to share their vaccine safety stories through VSafe and through VAERS. Any questions for Dr. House? I don't see any hands raised. Are there any questions from our liaison members for Dr. House on VSafe? Okay, we will then move on to go ahead, Dr. Duchin, just in time.
Thank you. I was slow on the button there, the raise hand button. Dr. House, thank you. Just a quick question. Can you comment on the preponderance of female respondents in the VSafe data that you presented?
Thank you for that question. I think you're probably referring to the booster doses in persons aged 16 to 24 years, where we had about 70% of participants who were female. This is more exaggerated than for primary series, and that might just be a reflection of females seeking out booster doses compared to males. But we will definitely look into that. And I will note that for our modeling, we do control for sex as well as race ethnicity.
Thank you so much for doing this important work.
Thank you.
Thank you. I don't see any additional hands raised, so we will move on to Dr. Nikki Klein, who will present updates on COVID-19 vaccine safety from the Vaccine Safety Data Link team. Dr.
Great.
Klein.
Thank you very much. I'm delighted to be here today, and good morning or afternoon to you. So today I'll be presenting on the Vaccine Safety Data Link rapid cycle analysis on uptake and safety in both 5 and 11-year-olds and mostly 12 to 17-year-olds. Next slide, please. So the Vaccine Safety Data Link, for those of you who are not familiar, is a collaboration between the CDC and 9 integrated healthcare organizations that include full electronic data and medical record information on more than 12.5 million of its members. Next slide. So the VSD's rapid cycle analysis, or RCA, the aims of the study have been to monitor the safety of COVID-19 vaccines weekly using pre-specified outcomes of interest among VSD members, and also to describe the uptake of COVID-19 vaccines over time among VSD members. We've been surveilling this and reporting since December 2020. Next slide, please. So here are the outcomes that we are monitoring. These have been in place since we've started the monitoring, and as you can see listed there, they've been applied to the 12 years and over population that I have reported on previously, as well as this is the same list of outcomes that we are going to monitor and that we have started monitoring for the 5 to 11-year-olds, which I will discuss briefly at the end of the presentation. Now, for the 12 to 17-year-olds, you can see highlighted as the myocarditis, pericarditis cases, which is will really be the focus of the rest of my talk for the 12 to 17-year-olds right now. Next slide. So a brief word about our myocarditis and pericarditis outcome. So here, these are the electronic codes that we've used to identify the cases. And on the left, these have been the codes that we have been using. You can see listed, and this was originally based on input that we received in consultation with cardiologists when we were designing this study well over a year ago. However, since that time, and since we've been monitoring it much more closely, we have actually recently revised our ICD code list based on feedback from other investigators and sites in the VSD with regard to how the codes are being actually used. And so we've, in addition to the 4 in black, you can see listed, we've added the additional 2 codes in red. Again, these are just in inpatient setting and emergency department settings. So for those of you who are paying close attention, you may note that there's an increase in the number of cases that would be a little bit more than incremental based on these, and they are due to the addition of these additional codes right here. Next slide. So for our analytic strategy for our RCA, the primary analysis, the number of outcomes observed in the risk interval, which has been 1 to 21 days after COVID-19 vaccination, were compared to the number expected. And expected were derived from what we've been calling the vaccinated concurrent comparators, who are in a comparison intervals on days 22 to 42 after COVID-19 vaccination. So on each day that an outcome occurred, vaccinees who are in their risk interval were compared with similar vaccinees who were concurrently in the comparison interval. And the comparisons were adjusted for age group, sex, race, ethnicity, VSD site, as well as calendar date. Next slide. So this is a figure I've shown previously, and what this is a demonstration of the analytic strategy I just described. And this shows a representative vaccinee with myocarditis who had myocarditis on June 3rd. So they were in their risk interval during 1 to 21 days after vaccination because they were vaccinated on May 30th. So on June 3rd, we found a similar comparator who are in their comparison interval that is 22 to 42 days after vaccination. And by a similar comparator, we mean that they're in the same age group and of the same sex, race, and at the same VSV site. And these are the analyses that I will be showing you in the subsequently slides. Next slide. So here is our vaccine uptake and analyses among 12 to 17-year-olds, and this data is as of December 25th. 2021. Next slide, please. So here you can see this is the Pfizer vaccine totals by week in adolescent age groups. And now, if you look at the x-axis, you can see this represents just about a year of time. So you can see that those in blue, the dark blue and light blue, represent the 12 to 15-year-olds, and then in orange is the 16 to 17-year-olds. And as you can see, that uptake within these different populations is fairly well reflected by the date on when the emergency use authorization was granted for each of these different age groups. Next slide. So regarding the myocarditis and pericarditis, we chart review all cases that occur under individuals under the age of 40 from 39 and under, review all of them. Today, I'll just be discussing those for 12 to 17-year-olds, but we do review all cases under 39 and younger. The data today reflects the chart was completed through December 30th, 2021 for 53 out of the 75 cases amongst 12 to 17-year-olds. And these cases were identified anytime after either dose of a Pfizer COVID-19 vaccination. So following initial chart review, all cases are adjudicated by an infectious disease clinician and or a cardiologist, and that is to confirm that the cases were incident following vaccination and they met the CDC case definition. So with adjudication, there were 47 out of the 53, or 89%, were adjudicated as a confirmed case. You can see the 43 were amongst the 12 to 17-year-olds occurred 0 to 21 days after vaccination, and 39 with onset 0 to 7 days after vaccination. Slide, please. So these are the characteristics from the validated or the chart reviewed cases for aged 12 to 17-year-olds in the 21 days after vaccination. This is, represents the 43 cases. And so what you can see is that there are 29, 12 to 15-year-olds and 14, 16 to 17-year-olds, and actually doing very rough estimates, the rates were approximately the same for both the two age groups when you take into account the number of vaccines given in each of the two age groups. For all these cases, the symptom onset had a median of 2 days. You can see the range, 0 to 20 days. And for the diagnosis, just over half were acute myocarditis, with most of the rest being myopericarditis and just 2 cases being diagnosed as acute pericarditis. Next slide, please. So with the exception of 4 cases, all the cases were admitted to the hospital. 65% were in the hospital, with the remaining 26% admitted to the ICU. I think it's 11 in the ICU. I will talk a little bit more about in a minute. The median length of stay for these cases was 2 days, and you can see listed that most were between 1 and 3 days, as you can see here, with a few more at 4 days and longer. Next slide. Oh, I'm sorry. One more thing is that they're all discharged home. All cases were discharged home. Next slide. So with regard to the cases that were admitted to the ICU for the 12 to 17-year-olds, they ranged in age from 13 to 17 years. They were all men, all males. The race, there are 5 Hispanics, 4 white, 1 black, 1 unknown. They were diagnosed 4 with myocarditis and 7 with myopericarditis. And among those who were admitted to the ICU during the hospitalization, the median length of stay for the entire hospitalization was 5 days. And then finally, the chart notes for 2 of the cases indicated that the ICU admission was preventative. And then there was an additional chart, so a 3rd case, where the chart was noted that the ICU admission was actually unrelated to the myocarditis. Next slide, please. So here's the analysis of these cases amongst 12 to 17-year-olds. Next slide, please. So this represents the vaccinated concurrent comparators, again, with the analytic strategy in the figure I showed you earlier, and focusing on both the 0 to 21 and 0 to 7-day risk interval, which is what we focused on because of our chart reviews. We found that many cases occurred around day 0. So when we look at after those two in the 0 to 21 days, you can see a very elevated rate ratio, 15.2, with high significant confidence intervals. And that is even more pronounced after the 0 to 7-day risk interval after dose 2, and you can see the rate ratio of over 46, with, again, highly statistically significant confidence intervals. One thing to point out, though, is that the excess cases were 70 cases per million doses, both for after dose 2 for both the 0 to 21 and 0 to 7-day risk interval, which indicates that all the risk is occurring during the 0 to 7 days interval. This is in contrast to the SS cases in the risk after dose 1, which was for 0 to 7 days, 0.3 cases per 1 million doses. Next slide, please. So we've been doing ongoing follow-up chart reviews for our validated cases. And these chart reviews are conducted 3 months after the initial diagnosis to obtain information on the symptoms and diagnostic evaluation of the most recent follow-up visit and the recovery status of the most recent follow-up visit. So as of December 30th, 2021, we've completed reviews for 32 cases among 12 to 17-year-olds that were time eligible in that for follow review, and that at least 3 months had passed since their initial diagnosis. So of these 32 cases, 24 had at least one follow-up visit at least 1 month since the initial encounter. So these 24 are the ones I'll describe the next couple of slides. Next slide, please. So for these 24 cases that had at least one visit 1 month after diagnosis, the time to discharge to the follow-up visit had a median visit of 88.5 days, is the range you can see there. But only 13, or just over half of them, actually had a follow-up visit of at least 3 months since the initial encounter. And then there are also 13 or...
That's too much emphasis on.
There's no new or worsening symptoms noted, or just over half of them. And then the ones who did still report some symptoms, it was 38% had reported chest pain, pressure, discomfort. There's far fewer of these individuals had follow-up diagnostic studies done, with exception of EKG. 75% of these cases, 18, had an EKG completed, and 50% of those were considered abnormal, so 9 of the 18. Next slide. And then in terms of the status of the most recent follow-up visits to these follow-up cases, 11 of these adolescents, or 46%, were noted to have no symptoms, or medications, or exercise restrictions as of the time of the review, with the remaining still on either symptomatic or still on exercise or physical activity restrictions, and a couple still on medication. Next slide. So turning to the 5 to 11-year-olds, and this will just be a brief update on our vaccine update and primary analysis, and this is from data through December 11th. Next slide. So here's just to show you the timing of when our doses were starting to be given within the vaccine safety data link amongst children 5 to 11-year-old. And like we've seen with previous age groups, you can see a large increase in uptake for vaccinations following the emergency use authorization for this age group. Next slide. So for a reminder, for our RCA analysis for our 5 to 11-year-olds, we're using the same methods for children aged 5 to 11 as I showed you and I've discussed for adults and adolescents, and the same outcomes as the list I showed you earlier in this presentation. In the vaccine safety data link, there's about 848,000 children aged 5 to 11 years. And as of December 25th, 431,485 doses of the Pfizer vaccine have been administered in this age group, over 257,000 are dose 1, and then almost 174,000 dose 2s. So in the 1 to 21 day risk interval, we've electronically identified a small number of cases for appendicitis. You can see 9 cases, seizures, which are 2, and then 2 cases of myocarditis and pericarditis. So far, the 2 potential cases of myocarditis and pericarditis have been chart reviewed. And of the 2, chart review verified 1 11-year-old acute pericarditis 19 days after dose 2, and the other case was not verified as a case upon chart review. And there have been no statistical signals that have been identified to date. Next slide, please. So in summary, for the analyses of safety amongst 12 to 17 and 5 to 11-year-olds, among 12 to 17-year-olds, the rate ratio for myocarditis pericarditis was elevated during days 0 to 7 after dose 2. The excess risk was 0.3 cases per million first doses, but it was 70 cases per million second doses. The VSD has administered over 431,000 Pfizer doses to children aged 5 to 11, and in the VSD, there have been no safety signals among 5 to 11-year-olds that we're continuing to monitor. Next slide, please. And I'd like to, as always, acknowledge just the hard work and really amazing work of our team here at Northern California Kaiser Permanente, as well as the CDC and Marshfield Clinic and all the VSD sites are very active participants in the chart review process. Thank you very much.
Thank you, Dr. Klein. And again, thank you to your team, as well as all the vaccine safety teams for working over the holidays to update and get this data to us. This presentation is now open for questions. Dr. Daly?
Thanks for that presentation, Dr. Klein. Could you go back to the slide showing the date that first and second doses of vaccine were given to 5 to 11-year-olds?
Sure. I think that slide 20. Could you go back there, please?
Okay, thanks. So Dr. Klein, could you speak to the idea so if kids in this age group were going to get myocarditis, we think that might happen in the 7 days after vaccination, particularly after dose 2. But could you speak to kind of how quickly that would be observed within the VSD in terms of sort of they need to come in and be seen, and then what's the sort of data lag, and when is that peak for the second dose happening? So I'm just sort of asking, do we have enough follow-up time for these kids to have potentially seen myocarditis after the second dose in 5 to 11-year-old kids? Thank you.
So as I think I mentioned, our data, generally the data lag is, as you're aware, is quite, we actually get data quite quickly. It depends, each VSD site's a little bit different. Some are a little bit more, have less data lag than other sites, depending on how the relationship with their inpatient hospitals. But in particular for this data actually goes through December 11th. So because of the holidays and what have you. So this data has not been updated since then. So there hasn't been a lot of follow-up time for those dose 2s to occur, which is if there is any risk for myocarditis, then it follows a similar pattern to what we've seen in the adolescents and young adults. It would be typically after dose 2. And so there hasn't been a lot of follow-up time to date for the dose 2.
Okay, thank you.
Yeah. Any other questions? I'm waiting to see if people would like to raise their hand. I actually just wanted to make a quick comment because every time I hear the data presented, I glean a little something different from it. And I think what was interesting is noting the long interval of follow-up. So many of these kids after discharge are not being followed up within a week or two. I think you said the median may have been 88 days, or mean was 88 days, I cannot remember. But suggesting that, those kids who are following up at 3 months post a hospitalization are probably doing their routine follow-up, but not necessarily are acutely ill, else I would have anticipated they would have come in sooner. So I think that's also helpful to see. Any other questions for Dr. Klein? Dr. Keeling?
All right, yes, thank you for this presentation. And it is impressive how much information you've been able to glean. I did want to ask you a similar question. And in the cases that you have seen, have you seen any deaths or any severe outcomes? Thank you.
Yes, thank you for that question. So we have not had any deaths. All the patients that we've been following in VSD all were discharged home after their hospitalization. With regard to severity, I think the best measure we have is those who were in the intensive care unit. And so, as I mentioned, that there were 11 of them who were in the intensive care unit, although 2 were for preventative measures and 1 for actually unrelated issues for the myocarditis. So I guess 8 out of those 43 that we have, I believe it was 43 that were perhaps in the ICU, if you want to consider that the severity. We don't have further information regarding what happened in the ICU. We're investigating that now.
Thank you. Dr. Daly?
Yeah, Dr. Klein, could you just explain for sort of the broader audience what you mean by preventive measures if somebody gets admitted to the ICU?
Well, as according to the chart notes, it was meant to be just in case the child decompensated or had clinical deterioration, to be available and already in a setting that could manage it, which is why the child was in the ICU, not because the child had the clinical indicators that required them to be in the ICU in the first place. It was more to be just in case something happened and that everyone would be ready to take care of the child should the child have some clinical deterioration.
Great. Thanks so much for that clarification.
Thank you. Are there any other questions? Well, I want to thank our presenters for an excellent series of presentations and updates on vaccine safety, both for the primary series as well as on booster doses. We will now take a break, and we are running behind schedule, so I'm going to suggest just a little over a 10-minute break. We'll plan to reconvene at 50 minutes after the hour, 50 minutes after the hour, after which we will return for public comments. So thank you, everyone, and look forward to reconvening soon.